This is a lecture about pathological myopia from the vitreoretinal perspective. Peripapillary atrophy, myopic crescent, or myopic conus. It is the sharply defined concentric area of depigmentation adjacent to the optic disc. It is due to peripapillary scleral expansion, that is to say, the inner surface of the sclera is visible. May be scleral crescent alone, or choroidal crescent, or both. Based on its extent, it can be a temporal conus, a nasal conus, inferior conus, or annular conus. The temporal conus is reported to be the most frequent type. Supertraction and tilted disc. The tilted disc is another issue that is found more than half of myopia cases. The cause of tilted disc or supertraction is that the retinal pigment epithelium and choroid is extending over the disc in the nasal aspect, while on the temporal side the retina falls short of the optic disc. Subsequently, the chorioretinal tissue may be dragged over the nasal edge of the disc with expansion of the posterior pole. Tessellation of the fundus. It is a generalized depigmentation due to retinal pigment epithelial atrophy that lead to tigroid appearance of the fundus. The areas of generalized atrophy don't have a well-defined margin, marked by the white asterisk, while we have additional focal areas of atrophy with well-defined margin, marked by the black arrows. What is macular chorioretinal atrophy? It is progressive thinning of the choroid with disappearance of the choroidal vessels, with loss of the retinal pigment epithelium and photoreceptors. It is due to choroidal vascular occlusion and biotrophic degeneration. Again, macular chorioretinal atrophy is classified into two types: diffuse atrophy and patchy atrophy. Diffuse atrophy appears as yellowish-white areas of atrophy with ill-defined borders, while patchy atrophy is a grayish-white, well-defined area of atrophy and produces an absolute scotoma on visual field. Macular chorioretinal atrophy may be presented by patchy atrophy that predispose to choroidal neovascular membrane development. Laker cracks. Laker cracks are breaks in the Bruch's membrane at the macula in highly myopic eyes. Laker cracks are associated with a posterior staphyloma, appears as a multiple yellowish-white regular line. Multiple irregular whitish or yellowish lines horizontally oriented and crossing the posterior pole. Laker cracks can be linear or stellate and sometimes show branching, crisscrossing, or both. Laker cracks commonly in males and decrease with aging. On fluorescein angiography, they lead to window defect and thus appear as hyperfluorescent tracks without any leakage. On fundus autofluorescence, Laker cracks appears as hypo-autofluorescent tracks. Laker cracks are hypofluorescent on indocyanine green. By OCT angiography, Laker cracks were identified as tracks of lack of decorrelation signal at the level of the choriocapillaris due to disruption of the flow. Laker cracks, also fresh Laker crack formation may be associated with subretinal bleeding in the absence of choroidal neovascularization. Laker cracks are frequently associated with formation of choroidal neovascularization at the margin or is in the adjacent area of the crack. Figure A, fundus image showing a well-defined curved hypopigmented line at the fovea suggestive of a Laker crack. Figure B, fluorescein angiogram highlighting the Laker crack as a hyperfluorescent line marked by the white arrow, OCT angiography image showing Leaker crack as a black curved line due to lack of flow detected as an area of lack of decorrelation signal. Forrester-Fox spot. It is a raised pigmented round or elliptical lesion. It is predominantly dark but can have a different hue, gray, yellow, red or green hue. It is named after Fuchs, who described the pigment lesion in 1901, and Carl Forrester, who described the new vascularization of the retina in 1862. Forrester-Fox spot arise due to proliferation of the retinal pigment epithelium with choroidal hemorrhage. These are primarily small scars formed following degeneration and new vascularization, which is related to high myopia. About myopic chorioretinal neovascular membrane. Macular choroidal neovascular membrane results in reduced central vision in patients with pathological myopia. It develops in about 10% of high myopes. 30% eventually develop choroidal neovascular membrane in the other eye. Myopic choroidal neovascular membrane, it appears as a grayish subretinal membrane with hyperpigmented borders. The OCT shows a hyperreflective elevated lesion in the subretinal space, usually without much exudative changes such as fluid under the neurosensory retina or intraretinal edema. These are generally type 2 choroidal neovascular membranes. Myopic choroidal neovascular membrane are predominantly classic type on angiography. They appear as a well-defined areas of hyperfluorescence in the early phase, with progressive leakage of dye in the late phase of the angiogram. Subretinal hemorrhage can be caused by both choroidal neovascular membrane and new Leaker crack formation in eyes with pathological myopia. OCT angiography can help to identify the choroidal neovascular membrane by a non-invasive technique. Features of active choroidal neovascular membrane on OCT angiography. The typical lacy wheel pattern, the numerous tiny capillaries, the widely anastomosed network, the perilegional hypo-intense halo. OCT angiography has been found to successfully detect up to 95% of myopic choroidal neovascular membranes. Figure A, fundus image of a myopic patient showing a grayish lesion at the fovea with pigmented margins, suggestive of choroidal neovascular membrane. Figure B, OCT angiography image of the same patient showing the branching network of vessels of the choroidal neovascular membrane with a surrounding dark halo. C, fundus fluorescein angiogram showing a hyperfluorescent choroidal neovascular membrane. D, indocyanine green angiography showing the hyperfluorescent choroidal neovascular membrane. Vitreous degeneration. In pathological myopia, there is vitreous liquefaction coupled with increased intraocular volume by the enlarging myopic eye. Consequently, there is posterior vitreous traction that may cause retinal holes, cystic degeneration, and retinoschisis. Also, pathological myopia is associated with posterior staphyloma. Posterior staphyloma is an outward protrusion of all coats of the posterior pole and is considered pathognomonic of pathological myopia. It is detected by the indirect ophthalmoscope easily. There are 10 different types of staphyloma according to Curtin. Its incidence increases with age, occurring mostly after the 5th decade of life. Posterior staphyloma formation is further linked to the development of myopic maculopathy. The eyes with shallow staphyloma show a large drop in visual acuity and a greater occurrence of choroidal neovascular membrane and macular hemorrhage. The normal choroidal flush is absent in high percentage of posterior staphylomas, suggesting the possibility of ischemia, which may further lead to development of choroidal neovascular membrane in these eyes. Dome-shaped macula is another entity in pathological myopia. Dome-shaped macula is a convex elevation of the macula within the concavity of the posterior staphylococcus. Probable pathological causes of dome-shaped macula include tangential vitreomacular traction, localized choroidal or scleral thickening, hypotony, and retinal resistance to scleral deformation. It may be the cause of unexplained visual loss in such eyes. Retinal detachment in pathological myopia. Highly myopic eyes have a tenfold risk increase of rheumatogenic retinal detachment. The relationship between the risk of detachment and the amount of myopia is linear. Myopia poses higher risk to develop retinal detachment following a blunt trauma. Both ab externo scleral buckle and ab interno pars plana vitrectomy are techniques for treating myopic retinal detachment. Procedures may be applied, but they have a lower success rate in highly myopic eyes. Peripheral retinal lesions or posterior paravascular tears and macular holes are the common finding. Lattice degeneration. In lattice degeneration, we have linear areas of retinal thinning, pigmentation, and branching white lines. Lattice degeneration, showing a pure snail track feature, is present in this image. Scleral buckling as a treatment for retinal detachment in pathological myopia carries some hazards and complications, including muscle avulsion, vortex vein damage, hemorrhage, subretinal fluid retention, globe perforation, and cataract development. Vitrectomy in high myopia is a technique with some hazards. The increase in the axial length and posterior staphyloma, so the standard instruments may be short or too short and therefore unable to reach the retinal surface, especially at the posterior pole. The instrument verticalization during surgery and the poor working angle are another difficulties. More posterior vitreous space and thinner sclera and incomplete posterior vitreous detachment is another issue. Complete posterior vitreous detachment may be even unachievable in some cases or in some eyes due to strong vitreoretinal adhesion and posterior shifting of the vitreous space. There is some notes in vitrectomy in high myopia. We should address the axial length and be scanned before surgery to plan the intraoperative approach. Increasing the distance between sclerotomies facilitates the vitrectomy and increase the working angle. The Rocker cannula should be inserted at 4 mm posterior to the limbus, also to the same purpose. Curved instruments and valved cannula is an important issue. The assistant should be qualified in doing peripheral indentation. Switching the hand of the vitreous of the cutter facilitates surgery. Avoid intraoperative cataract formation and touching the lens. Self-healing sclerotomies may not always remain tight after surgery, remember this. Peripheral vitrectomy with meticulous vitreous removal to prevent redetachment or proliferative vitreoretinopathy is an important issue. Use something to assist to see epiretinal tissue, like chromovitrectomy using dyes, like filters in the microscope, like 3D surgery or intraoperative OCT. The type of tamponade in retinal detachment in pathological myopia. The irregular contour of the vitreous cavity, posterior staphyloma, and peripheral ectasia affects tamponade efficacy. Gas tamponades perform better than silicone. Remember that gas tamponade in this conditions perform better than silicone. Silicone oil fail to tamponade irregular scleral contours. Gas tamponade should be preferred to silicone oil in these eyes. Again, myopic maculopathy. Myopic maculopathy is a common finding because of the excessive axial elongation causing posterior staphyloma. It is because of myopic foveus cases and the myopic macular hole, which alternatively described as myopic tractional maculopathy. Myopic tractional maculopathy in addition include other conditions such as retromacular traction, retinal thickening, lamellar or full thickness macular hole formation, and foveal detachment. Myopic tractional maculopathy always occurs within the posterior staphyloma. We have also myopic foveus cases. It occurs in 9% of highly myopic eyes with posterior staphyloma. Myopic foveus cases is the splitting of the retinal layer in the macula, causing accumulation of intraretinal and subretinal fluid at the macula in the absence of a full thickness macular hole. It is asymptomatic in early stage. Vision loss occurs with the lamellar hole formation or foveal detachment. Fundus examination might detect mild amount of subretinal fluid in the macula. Small amount of subretinal fluid associated with early stage of myopic foveus cases might be very difficult to detect on the fundus examination, and therefore spectral domain optical coherence is beneficial. Myopic macular retinoschisis. The pathogenesis behind myopic tractional maculopathy is splitting of the retina over time due to relative tautness and non-compliance of the inner retina compared to the outer retina within the posterior staphyloma. Abnormal traction caused by the posterior hyaloid surface. The split occurs at the level of the external limiting membrane. Surgery is indicated in patients with symptomatic metamorphopsia and progressive visual loss. Without treatment, the condition may progress to macular hole and complete retinal detachment. Thank you.